Hello, my name is Dr. Sindhu Johnson, and I'm a professor of medicine at the University of Toronto. I would like to thank RheumNow for the opportunity to share with you application of the ACR CHEST guidelines for the screening, monitoring, and treatment of scleroderma-associated ILD as well as rapidly progressive ILD. Case 1. A 55-year-old male is referred to you for evaluation of systemic sclerosis. He has Raynaud phenomenon since 2019, puffy fingers since 2023, and symptoms of gastroesophageal reflux disease, joint pain, poor sleep, pruritus, fatigue, and mild shortness of breath. His blood work is fairly unremarkable, with the exception of elevated ESR, an elevated CRP, and positive SCL-70 antibodies. On physical exam, his lungs are clear to auscultation. However, his modified rod and skin score is 23 out of 51, with flexion contractures of his hands and skin thickening of his hands, arms, legs, and face. When we apply the American College of Rheumatology, American College of Chest Physician guidelines, there's a conditional recommendation to screen with pulmonary function tests, that is spirometry, lung volumes, and diffusion capacity, as well as high-resolution CT chest. We performed these tests and found that his FVC was 77% predicted, TLC was 73% predicted, and his DLCO was 73% predicted. A CT chest demonstrated bibasilar fibrosis. When we consider his risk for not only having ILD, but also progression of ILD, he has a number of risk factors. He's SCL-70 positive, he has the diffuse subtype, he's male, and he has early disease with acute phase reactants. So not only can we make a diagnosis of interstitial lung disease, but because he has shortness of breath, radiographic findings, and risk factors, one would choose to treat his interstitial lung disease. In this case, the guidelines have a menu of options that we can choose from. Mycophenolate, which is the first-line treatment, but also one could consider tocilizumab, rituximab, cyclophosphamide, nintedanib, and azathioprine. There is a strong recommendation against the use of glucocorticoids due to the risk of inducing a scleroderma renal crisis. So in his case, he was prescribed mycophenolate mofetil at 1,000 milligrams twice a day. The next grouping of recommendations relates to monitoring. And so it is recommended that in people with systemic sclerosis, they undergo pulmonary function testing every 3 to 6 months in the first year and then less frequently once stable. In addition, it is conditionally recommended that they undergo ambulatory desaturation testing every 3 to 12 months, as well as high-resolution CT chest. On follow-up, his mycophenolate 1,000 milligrams twice a day is continued. He denies fatigue, and pruritus has improved. However, he complains of shortness of breath with one flight of stairs and now a mild cough. He continues to have skin thickening with no improvement. His repeat pulmonary function tests show a reduction in FVC to 69% predicted and his DLCO at 66% predicted. Again, repeat pulmonary function testing shows further decline in his FVC to 67%, as well as his DLCO to 65%. His ESR is normal, but his CRP is elevated at 1.12 and his HAQ-DI is 1.5. Repeat CT scan of his chest demonstrates worsening fibrosis now migrating to the midzones. In this case, we can say that he has progression of his ILD despite mycophenolate therapy. So the guidelines present another menu of options for those who have progression despite first-line therapy. These include mycophenolate, if mycophenolate was not the first-line therapy, rituximab, nintedanib, tocilizumab, cyclophosphamide, referral for consideration of autologous hematopoietic stem cell transplant. There remains a strong recommendation against long-term glucocorticoids in these patients. And at this point, one may consider referral for lung transplant evaluation. In his case, he was treated with nintedanib. However, an equally reasonable option would be to switch or add tocilizumab or switch or add rituximab. Case 2. a 63-year-old male with antisynthetase syndrome. He was diagnosed with idiopathic inflammatory myositis in 2020 when he presented with symptoms of muscle pain, fatigue, shortness of breath on exertion, and cough. He had evidence of mechanics hands, proximal muscle weakness in his upper and lower extremities. His CK was elevated at 2,800. His EMG demonstrated fibrillation potentials, and his MRI with stir imaging revealed muscle edema and inflammation. His serology was positive for Jo-1 antibody. Based on the recommendations, he was screened for ILD and underwent pulmonary function testing, which revealed an FVC of 71%, TLC of 77%, and a DLCO of 67%. His CT chest revealed bibasilar fibrosis. In this case, first-line treatment of myositis ILD includes mycophenolate, azathioprine, rituximab, a calcineurin inhibitor, JAK inhibitors, cyclophosphamide, and short-term glucocorticoids. So in his case, he was started on mycophenolate 500 BID as well as prednisone 60 milligrams a day. That mycophenolate was increased to a maintenance dose of 1,000 milligrams twice a day, while his prednisone was tapered over 10 months. However, in 2021, he comes back to clinic with a non-productive cough of 3 months and slow worsening of his shortness of breath over 2 months. His repeat pulmonary function tests show a decline in his FVC to 56%, a decline in his DLCO to 46%, and although there was an improvement initially in his CK to 400, it is now increased to 840. In this case, where we have progression of ILD in someone who has myositis despite treatment of mycophenolate, there again is a menu of options that one can choose from. These include rituximab, a calcineurin inhibitor, nintedanib, cyclophosphamide, IVIG, and JAK inhibitors. While one could consider short-term steroids, there is a conditional recommendation against long-term steroids. The plan for him was to repeat the high-resolution CT chest, rule out infection, and consider addition of moderate doses of prednisone and rituximab. However, a month later, he comes back to clinic with a sudden and significant worsening in shortness of breath in the past 7 days. He's unable to walk even a few steps without shortness of breath on exertion, and so he went to the emergency room. There, they do not identify fever, but he is tachypnic. His oxygen saturation is 88%, requiring 3 liters of binasal prongs. His EKG shows sinus tachycardia with no other abnormalities, and they rule out pulmonary embolism. Repeat CT chest reveals marked worsening of his interstitial lung disease. In this case, we can make a diagnosis of rapidly progressive ILD. That is a subpopulation of those who have ILD that is characterized by rapid progression from no oxygen to a baseline level of oxygen to high oxygen requirements or intubation, occurring over days to weeks without documented alternative cause such as infection or heart failure. In this case, the guidelines conditionally recommend combination therapy with IV glucocorticoids plus 2 additional therapies. In his case, he was treated with pulse steroids and rituximab 1,000 milligrams 2 weeks apart, that is 2 doses, and he was continued on his mycophenolate 1,000 milligrams twice daily. He was discharged from hospital on 60 milligrams of prednisone that was tapered over 12 months. And as you can see from this table, there was a progressive improvement in his forced vital capacity, his predicted from a low of 54% up to 70%, an improvement in his DLCO from 32% to 58%, and an improvement in his CK from 840 to 54. So I have tried to demonstrate for you the application of the ACR and CHEST guidelines. These guidelines provide a risk-based approach for the screening and monitoring for SSc-ILD and rapidly progressive ILD. These guidelines provide a range of treatment options based on the best published evidence, expert experience, as well as patients' preferences and values. I'd like to thank everyone who was involved with the development of these guidelines. And finally, thank you for your attention.